Hi, this is Jeremy Warner, and I'm presenting the first analysis on behalf of the COVID-19 and Cancer Consortium, the clinical impact of COVID-19 on patients with cancer. Our website is below, as well as our Twitter handle. We're also registered on clinicaltrials.gov. A little background. So the effects of COVID-19 on patients with cancer remain poorly understood. There are some published reports, but they tend to be on the smaller size or focused on a specific geographic region. We wanted to collect a larger and more representative cohort to learn more about the impact of COVID-19 on cancer, with the anticipation that patients with cancer could be at greater risk due to overall increased age, more comorbidities, more healthcare system contacts, especially for patients on treatment or getting scans or getting blood draws, a decreased immunity due to cancer or the treatment for cancer, and a decreased performance status in general. Our consortium was founded on March 15th, roughly 2 months ago, and began to take reports 2 days later. We're open to site-level participation in the US and Canada, and also open to anonymous reports from individuals in several other countries and regions. Our survey is designed for real-time reporting as well as reporting after a course of COVID-19 illness. We now have 104 participating institutions, and 928 cases were included in this first analysis. Here are some descriptive results. On the upper left, you can see that half of our patient population was male, and the median age was 66 years, which is much older than median age reported for other more general COVID-19 populations and consistent with the cancer diagnosis. Of note, 30% of these patients were older than 75. Half of them were white, 16% were Black or African American, and 16% were Hispanic. Of note, if you look at the census distributions of race and ethnicity based on our geographic regions, the numbers of Black or African American patients is about double what you would expect based on census representation. 39% of these patients were on active anti-cancer treatment, defined as either cytotoxic chemotherapy or other therapies such as targeted therapies. And 43% had active or measurable cancer. If you look on the right, we have the most common cancer types. Breast cancer was the most common at 21% of the reports, followed by prostate cancer, gastrointestinal cancer, lymphoma, and thoracic cancer, which includes lung cancer. Most of our patients had an ECOG performance status of 0 or 1, although 8% had an ECOG performance status of 2, which I'll talk about on the next slide. Half of our patients were never smokers, a third were former smokers, and a small number, 5%, were current smokers. Looking at the outcomes, first of all, I want to note that the follow-up on this cohort is quite short, with a median of 21 days or 3 weeks, and that reflects the urgency and rapidity with which we've collected this data. At this point, 121 patients, or 13%, have died, and all of those died within 30 days of their COVID-19 diagnosis. Looking at the left table, again, the baseline being 13% rate of death, and that's about twice what the report is for all patients across the globe, which is about 6.5%. Looking at some subgroups, you see that male sex is associated with a higher death rate, as is former smoking, and especially in age greater than 75, 25% rate of death. We also found associations with having active cancer, whether it's stable and responding to treatment, but especially if it's progressing. We found that patients with an ECOG performance status of 2 or higher had a death rate of 35%. And if you look below, we define ECOG performance status of 2. Notably, this is slightly impaired by the cancer, but not severely impaired. Really, the only characteristic that we found associated with a lower rate of mortality was not having any comorbidities, although the number of deaths in that group was small, and this does not reach statistical significance. We did not find statistically significant different rates of death for based on race or ethnicity. Looking on the right, we've also looked at some other outcomes besides death. We see that 50% of this cohort was hospitalized, and of those, 23% ended up dying. Of the 14% who were admitted to the ICU, 38% died. Of note, a few patients who are admitted to the ICU have subsequently recovered, about a third. If If you look at some smaller subgroups, you start to see very high death rates. Patients who are over the age of 75 and were admitted to the ICU, more than half of them died. And patients who had an ECOG performance status of 2 admitted to the ICU, 2/3 of them died. Looking at intubations, notably, this is a slightly different outcome than admitted to the ICU. Not everybody admitted to the ICU gets intubated, and likewise, some patients get intubated in settings other than the ICU, especially in very busy hospitals that are experiencing surge capacity issues. Of these patients, 43% died at baseline. Those aged 75 and over, 59% died, and of those who had a performance status of 2 and were intubated, there's only 13 patients, but 11 of them died for a death rate of 85%, extremely high. So in conclusion, the mortality in this cohort was high and was associated with general population risk factors such as sex and smoking status, as well as those unique to patients with cancer. In our multivariable logistic regression model, independent factors that were associated with increased mortality were older age, male sex, former smoking, number of comorbidities being high, an ECOG performance status greater than 2, active cancer, and receipt of the combination of azithromycin and hydroxychloroquine. I will caution that this final result is of uncertain validity due to a high risk of residual confounding. For example, patients receiving this combination were more likely to have severe disease or more likely to be hospitalized. As I discussed in the previous slide, there are certain subsets of patients with cancer that had very poor outcomes. Overall, we need a larger sample size and longer follow-up to more completely understand the impact of COVID-19 on specific patient subsets, such as those with certain types of cancer, and what happens over time beyond this short initial period.